Hello and welcome to this touch-in conversation activity. My name is Dr. Shounak Majumder, and I'm joined by Professor Matthias Löhr. Today we are going to discuss addressing challenges in the diagnosis and treatment of IgG4-related gastrointestinal disease, and we'll start off the discussion with the topic of challenges of diagnosing IgG4-related gastrointestinal disease. So IgG4-related disease is a progressive immune-mediated condition. This was defined a couple of decades ago, and it's a multi-system disease, so it's fairly common for patients with IgG4-related disease to have two or more organs involved at the time of initial clinical presentation. In terms of organs involved, it can essentially involve any organ in the human body, but commonly involves the salivary glands, the kidneys, blood vessels, and in the GI tract, the pancreas, the bile duct, the liver, and the retroperitoneum. What's characteristic of this condition, it often follows a relapsing remitting disease course and can present as enlargement of an organ or a mass that raises the suspicion of cancer. It can frequently affect the pancreatico-biliary tract, and actually pancreatico-biliary involvement and liver involvement is one of the more prevalent phenotypes of this disease. And autoimmune pancreatitis type 1 is essentially the pancreatico-biliary manifestation of type 1 of IgG4-related disease. And the clinical presentation of IgG4-related disease when it affects the pancreatico-biliary system commonly includes jaundice. Patients can present with a pancreatic mass or a narrowing or a biliary stricture. And they may also present with weight loss and abdominal pain. However, cholangitis, which is characterized by jaundice, pain in the right upper part of the abdomen, sometimes with fevers, is a fairly common manifestation of pancreatico-biliary IgG4 disease, especially when it involves the head of the pancreas or the bile duct. So we'll start off with our first question to Professor Löhr here. How are the pancreatico-biliary manifestations of IgG4-related disease diagnosed, and what guidelines or expert consensus statements are available to support the diagnosis?
Yeah. As you just said, the symptoms include abdominal pain, for instance, which could be a symptom of acute pancreatitis, and jaundice. So those are the two major symptoms in the majority of cases. And you could then, if you suspect this, take the IgG4 level in serum, which would be indicative that this indeed is this IgG4-related disease. And the other things to be done with some kind of imaging, CAT scan or MRI, to really make this diagnosis. Now, the guidelines were both issued by the American College of Rheumatology and the United European Gastroenterology for the IgG4-related diseases. And the ACR has really coined both the cholangitis and also the pancreatic affection as emergency indications for therapy.
Yes, I think that leads us to our second question is when patients present acutely and there's a need to start treatment or initiate some kind of intervention right away, what are some of the important differential diagnoses of this condition of IgG4-related pancreatico-biliary disease, and how does evaluation for these disease mimics factor into not only the diagnostic workup, but the need to initiate treatment as soon as possible?
Yeah. In stark contrast to other manifestations of this disease, particularly the manifestation in the pancreas could indeed mimic a pancreatic tumor, not to say a pancreatic cancer. For so that matter, you must positively exclude a cancer and or positively diagnose IgG4-related diseases. If you have a mass in the pancreas and have a high level of IgG4 in serum, this would make the diagnosis of IgG4-related disease and autoimmune pancreatitis type 1, as you would call it. If in doubt, you could do some endoscopic ultrasound with or without biopsy taking. And if in doubt, then obviously such a patient should undergo surgery. even in a center like ours at Karolinska, where we see hundreds of patients with pancreatic diseases a year. Every year we do 2 to 3 surgeries in patients where a cancer is suspected, but then in the surgical pathology, it turns out to be autoimmune pancreatitis. Now, the same holds true for the cholangitis, which could mimic cholangiocarcinoma, but normally the picture is a little bit more typical compared to the manifestation in the pancreatic gland.
Yeah, thanks for highlighting that clinical dilemma of pancreatic cancer and pancreaticobiliary involvement of IgG4-related disease. I think it's critically important to rule out an underlying malignancy, because that will definitely impact the management and outcomes of a given patient. Can we expand maybe a little bit more on presentations with biliary involvement? So PSC is a fairly common stricturing biliary disease that, when I say common, it's a common differential diagnosis of IgG4-related involvement of the biliary tract. Could you maybe share with our audience some similarities or differences between IgG4-related sclerosing cholangitis and PSC?
Yes, the IgG4-related cholangitis, for the most part, really manifests itself in the distal bile duct, and particularly in the intrapancreatic part of the bile duct. So that is one huge difference. This is, of course, accessible not only to MRI, MRCP, but also to ERCP if so needed. And then one could do both a brush cytology or even biopsies with a modern instruments to really rule out this kind of differential diagnosis. For the educated radiologist, I have to say, the differential diagnosis is, I shouldn't say easy to be made, but is to be made. But I say this one more time. I mean, even at our center, 2 or 3 cases per year go to surgery with a suspicion of pancreatic cancer. Now, if this is really doubtful on imaging, what we do, and this is in line with the European, but also the Japanese guidelines for autoimmune pancreatitis, we do a steroid treatment trial, but with the understanding that you really have to redo the imaging 2 to 3 weeks after initiating the trial, the steroid therapy, that is. And I mean, the swelling of the pancreatic glands is really melting away within this short period of time. So in the Japanese guidelines, this response to therapy is a diagnostic criterion.
Yes, and we'll talk in a little bit more detail in later sessions on the role of steroids in this disease. I think it has, as you rightly point out, both a therapeutic role as well as a diagnostic role. And just understanding how to use it and when to use it as a diagnostic criteria is important. So, we have heard from you a little bit on, okay, this is, somewhat challenging to diagnose even at referral centers. We should think about cancer always when we are making this diagnosis, make sure we have done due diligence to rule out an underlying biliary or a pancreatic malignancy. What strategies can be implemented to facilitate a prompt and an accurate diagnosis? There's some emerging evidence showing that there's really a prolonged period of time between the onset of symptoms and established diagnosis in this condition, and you indicated in your opening comments about the urgency of making the diagnosis and intervening. Do you have strategies that could shorten that time period?
We both come from centers who are very well known for their, expertise in pancreatic diseases, but this is not, the case across the board, so to say. So to start from the end, really, is to raise the awareness that there is such a disease as autoimmune pancreatitis or biliary pancreatic disease as part of the IgG4-related diseases, number one. Number two, then, of course, as said before, you can measure IgG4 in serum, which is good if it is positive, obviously, but we lack really good biomarkers for not only the IgG4-related diseases in general, but particularly for some of those organ manifestations. There have been some autoantibodies associated particularly with autoimmune pancreatitis, but due to the lack of commercial availability, you cannot use them in clinical practice. Now, the really thing important here is that you think of it, do some imaging in a patient who has jaundice, who has some abdominal pain, and maybe even weight loss sometimes, all of which could be indicative of a cancer, obviously. So not different from the differential diagnosis of pancreatic cancer, one really should follow up such a patient and do not delay any kind of diagnostic measure.
Yeah, that's wonderful. Thank you, Professor Löhr. So I think reducing the time between symptom onset and diagnosis is critical. And for that, understanding the differential diagnosis, being aware that this is an entity that can often mimic a pancreatic or biliary malignancy, but always rule that out, keep this on the differential list and kind of move through the diagnostic possibilities quickly. So thank you to Professor Löhr for his insights, and thank you all for watching. Next, we will discuss IgG4-related pancreatitis and how to differentiate type 1 autoimmune pancreatitis from type 2 autoimmune pancreatitis. Thank you.
Thank you.
Hello, I am Dr. Shounak Majumder, and I'm joined by Professor Matthias Löhr. The second topic of discussion is IgG4-related pancreatitis, differentiating type 1 autoimmune pancreatitis from type 2 autoimmune pancreatitis. So when we think about type 1 autoimmune pancreatitis, it's a male predominant disease typically affecting patients in the 6th to 7th decade of life. And some of the common clinical manifestations of this condition actually mimic a pancreatic malignancy. So patients can present with weight loss, with jaundice, with imaging often demonstrating a mass in the pancreas. Some patients may also present with an acute inflammatory pancreatitis type presentation. And the disease may present in a more acute presentation or a more chronic form. The acute presentations are with obstructive jaundice, with cholangitis, with abdominal pain and a pancreatic mass, although pain is not very frequent. And some patients present with a more chronic form of the disease where it actually mimics chronic pancreatitis and can present with pancreatic atrophy. What's characteristic of this condition is that it often follows a relapsing course. So my question for you, Professor Löhr, is what is the clinical overlap between type 1 autoimmune pancreatitis and type 2 autoimmune pancreatitis?
Actually, the overlap is not so huge, to be honest, but maybe for pancreatic manifestation. Now, IgG4-related disease, that is autoimmune pancreatitis type 1, mostly presents as a homogeneous swelling. It's also called the German Bratwurst in MRI or CAT scan, but it can also have, a lesion, a tumorous lesion, a swelling in the pancreatic head, and that would be something you would also see in type 2 autoimmune pancreatitis. So that is really maybe the only really overlap. Other than that, it is rather distinct from the type 1 IgG4-related disease, both in, as I said, the manifestation within the gland, but then also you rarely see other organ involvement the way you see that in IgG4-related disease / autoimmune pancreatitis type 2, but an association with inflammatory bowel disease. So typically, we identify or diagnose rather type 2 autoimmune pancreatitis because, say, a patient with Crohn's disease has still abdominal pain while under ongoing therapy, and then the imaging shows some swelling or even a tumorous lesion within the pancreas. And obviously these patients with IBD who are under therapy do not need an extra anti-inflammatory therapy for their type 2 autoimmune disease, but obviously, even if it is described here as rare, which is true, some therapy of the exocrine pancreatic insufficiency.
Yeah, that's wonderful. So what you heard is that there's actually very little overlap. These appear to be fairly distinct clinical entities. There's probably some similarity on the imaging side of things, but type 1 autoimmune pancreatitis is a IgG4-mediated disease, whereas type 2 is not. And type 2 autoimmune pancreatitis has an association with inflammatory bowel disease, which is actually a defining feature of this condition. So the next question gets at how we diagnose AIP type 1 and how the diagnostic criteria of this condition maybe differ from other forms of AIP.
Yes. I would like to follow the so-called HISORT criteria, which were actually developed by Mayo Clinic 10 or 15 years ago, I believe. And this is a very nice acronym because it includes all of the 5 elements, which is histology. So if you take a biopsy or have a surgical pathology of a mistakenly resected pancreatic head, then you would see this, what is called storiform fibrosis, which is very typical. Even a venulitis, obliterative phlebitis in the tissue is very, very specific. And then obviously the IgG4 positive plasma cells, more than 10 per high power field, are the diagnostic threshold, which really determines that this is IgG4 related disease, that is autoimmune pancreatitis type 1. Then you may have other features which are maybe not so prominent. Then in imaging, as I said, typically in the pancreas it is a swelling of the gland, which again is called German Bratwurst. There is a contrast enhancement at the margin, the rim around the pancreas, very, very typically. And if there is also other organ involvement of the bile duct, then you see the contrast enhancement in the distal bile duct going through the pancreatic gland. So that is in imaging very, very typical. With regard to what you can measure in the blood, the serology that is, it is of course IgG4 in serum. Sometimes only the IgG4 total is elevated. And then the other organ involvement would be, for instance, that you see the immune-related cholangitis, which we mentioned before. But then also there are very pathognomonic, I should say, lesions in the kidneys. That is not to say that the patients have some kind of renal insufficiency, but the lesions in the kidneys are pathognomonic, and together with the swelling of the pancreatic gland and maybe some affection of the bile ducts make the diagnosis of autoimmune pancreatitis type 1. And finally, if in doubt, you can even use the response to therapy, that is to steroid glucocorticoid treatment, as a diagnostic measure, because within 2 weeks, the swelling of the pancreatic gland and the stenosis in the bile ducts should vanish. They really melt like ice in the sunshine.
Yeah, I think that's a great summary of the HISORT criteria. As we have discussed previously, the glucocorticoid response can be diagnostic, but there needs to be some pretest probability of the disease when we are kind of trying to establish the diagnosis with a response to steroids. I think you bring out a very relevant point of the rim enhancement. That's a very characteristic feature on imaging, as well as looking for other organ involvement, because oftentimes it's not the pancreatic features on imaging, but the presence of clearly indicative involvement of other organs is what helps clinch the diagnosis. And you had mentioned imaging patterns. Would you want to elaborate on that a little bit more here?
Yes, as said, this general swelling of the gland is the most typical, but you may have, as mentioned before, a tumor, which simply means a swelling at one, location within the gland, which could mimic a pancreatic cancer, and sometimes even, manifestations at 2 or 3 sites within the pancreatic gland. This is rather rare, but these are the 2-3 major manifestations of autoimmune pancreatitis within the pancreatic gland.
Yeah, that's wonderful. So multifocal stricturing is often present, and the absence of duct dilation should raise the possibility of autoimmune pancreatitis. The main pancreatic duct is often not dilated, but strictured down in more than one place. So given that, we have been talking about cancer quite a bit in the context of AIP, I think one of the questions that come up is AIP associated with an increased risk of malignant diseases, either in the pancreas or outside the pancreas, and how does that risk differ between type 1 and type 2 AIP. Your thoughts on that, Professor Löhr?
Yes, stemming from the Honolulu consortium, we looked retrospectively in that, and there's also a prospective study from Japan which shows there are malignancies associated with autoimmune pancreatitis. Now, interestingly enough, the number one hit is not pancreatic cancer but gastric cancer, and there is maybe some rationale to that because there has been shown that there is a molecular mimicry between, antigens, autoantigens in the pancreatic gland and H. pylori. However, we and others could not show a direct link or a presence of H. pylori DNA or bacteria in the pancreas. So the mechanism must go through the manifestation or presence, I should say, of H. pylori in the stomach, really. Now, with regard to pancreatic cancers, this is an interesting story. 1/3 is synchronous. That is to say, you diagnose a lesion in the pancreas, which turned out to be autoimmune pancreatitis, but you also have at the same time a pancreatic cancer. So there, and that we have learned from a pathologist, you may have an autoimmune reaction surrounding a pancreatic cancer. It is obviously fundamentally different if you turn to the metachronous occurrence of pancreatic cancer 2, 3, 4, and 5 years after the diagnosis of autoimmune pancreatitis. This clearly is not something which occurred together with the autoimmune pancreatitis, but developed later on. What we do not know yet is whether this is an obligatory pre-neoplastic condition, such as ulcerative cholangitis for the UC-related colorectal cancers, or whether there is another mechanism involved.
Thank you for your insights on this important topic, and I'd like to thank Professor Löhr for his comments, and thank you all for watching. Next, we will discuss therapeutic strategies for IgG4-related gastrointestinal disease. Thank you. Hello, I am Dr. Shounak Majumder, and I'm joined by Professor Matthias Löhr. The third topic of discussion is therapeutic strategies for IgG4-related gastrointestinal disease. So when we think about treating pancreaticobiliary manifestations of IgG4-related disease, the first line of therapy is glucocorticoids, and we'll typically use prednisone or prednisolone, depending on what's locally available. And here in the US, we'll start with a dose of 40 milligrams of prednisone once a day. We'll continue that for a period of at least 4 weeks, assess response, and then start tapering by 5 milligrams. The need for continuing glucocorticoids or any other form of maintenance of remission therapy is not critical in every patient, because some patients will respond to treatment and not develop a relapse. And so we do not routinely place patients on some form of maintenance therapy. However, recognize that relapses are not infrequent in this condition. And so it's really important to have a plan in place for monitoring these patients for relapse and then treat a relapse when it happens. And the choices of treatment for relapsing disease include steroids or prednisone, but there are a few other classes of medications that can be considered, and we'll discuss that in detail with Professor Löhr here today. So the first question for you, Professor Löhr, is how do you assess the response to glucocorticoid therapy in patients presenting with pancreaticobiliary manifestations of IgG4-related disease, and what results, either clinical or imaging-wise or biochemical, would you use then to consider starting a steroid taper?
Obviously, the first response to be observed and monitored is the clinical response. That is, that the patients do no longer have abdominal pain, that the jaundice obviously is going away, that they put up some weight, which in part may also be due to the steroids, obviously. And then if you do a follow-up imaging, that you see that, again, the thickening of the biliary duct system and the pancreas is reduced. You can also use the so-called IgG4-related disease responder index, which is a very nice tool to basically have an objective measurement, not to say an index which you can put in your patient records. The autoimmune pancreatitis type 1 is responding as the type 2 very well to the first course of steroid treatment, about 80% in the first go, so to say. The rare patients with autoimmune pancreatitis type 2, which have not yet developed an IBD, also respond very well, and they do not have any kind of recurrence of the disease, and the recurrence rate obviously in autoimmune pancreatitis type 1 is much higher. You must follow those patients for a variety of reasons. Number one, the already mentioned risk for recurrence. Then, as we and others have shown, there is a tendency for the atrophy of the pancreatic glands, and with that comes pancreatic exocrine insufficiency, which needs to be treated. Again, an ACR indication for emergency treatment, so to say. Then they may also develop diabetes later on, for instance, and then there still is the risk to develop a cancer further on. So those patients need to be in your follow-up, in your surveillance, in your clinic, to be monitored and taken care of in case there is something which is developing, say, endocrine exocrine insufficiency or recurrence.
Yeah, thank you. I think one of the key takeaways there is the response to steroids. And if you reassess the patient in a few weeks and you're not seeing a steroid response, that should really put the diagnosis in doubt because this disease, both type 1 AIP and type 2 AIP are both exquisitely steroid responsive.
Yes.
The next question then kind of, linking to that role of steroids is, what are the limitations of glucocorticoid treatment? We have both stated that steroids are the first line of treatment. The disease usually responds really well to steroids. So what are some of the limitations, and are there any steroid-sparing options that are currently available for treating pancreaticobiliary IgG4-related disease?
Let me just briefly go back on the first course of glucocorticoid treatment. The ones who have very high IgG4 levels, you could also monitor the dip in IgG4 in serum, for instance. But if they have other organ involvement, those are the ones who are more prone to have a recurrence. Number one, we have learned, this is some evidence from some Japanese studies, that they are those who profit from a low steroid maintenance therapy. So those are the ones where would go on with a very low 5 milligram dose, say up for a year. Now, what could you do to take other drugs? You mentioned already there are other immunosuppressive therapies such as azathioprine, methotrexate, mycophenolate, and others. We have again learned from the rheumatologists who are very much more, how should I say, used to use biologicals, that one should hop over the use of so-called other immunomodulant therapies and go directly to biological, that is CD19, CD20 inhibitor, or antibody rather, which of course is off-label use for the time being. So we have learned again that if you have a relapse, if the patients are not responding to the first glucosteroid therapy, that we use rituximab.
Yeah, and you bring up a good point about some of these maintenance therapies or treatment options for relapsing disease are off-label choices, but fairly widely used in clinical practice. And would you mind sharing kind of your view of the use of rituximab in this disease, which seems to be a fair bit of accumulating evidence supporting its clinical role in maintenance and in treatment of relapsing disease?
Maybe I can go back a couple of years where we played around with all of those, azathioprine, methotrexate, mycophenolate, and so forth, and it was always difficult to handle these patients, right? So there is not only the better clinical and therapeutical effect of the biologicals, there's also the relatively ease of handling this. And I say this one more time, this is something with regard to the rituximab we learned from the rheumatologist. So if we have a recurrence, we do not play around with other drugs. We use off-label rituximab, and in my personal experience, those patients do not have another bout or recurrence of the disease. So it is really a very good therapeutic principle, which we can come to elaborate on a little bit further, I suppose.
Yes, and I agree with you that in our clinical experience, rituximab seems to not only be effective in inducing remission, but maintaining remission in the long term. So its role in the management, especially of the type 1 AIP patients, as you referred to in your earlier comments, that relapses are really infrequent in type 2. So this discussion about maintenance therapy and how to treat relapses is really pertinent to the management of type 1 AIP and not type 2. But in that group, especially those with biliary disease, with extensive extrapancreatic involvement, a higher risk of relapse, we're searching for a maintenance therapy option that can maintain remission and is tolerated well by patients. So on that theme, what are some of the emerging treatments that are currently in clinical trials and clinical development for treating pancreaticobiliary IgG4 disease, and how do you think these would impact the future treatment landscape?
If I may briefly go back to the treatment with steroids and what you do in the biliary tract disease. This is not evidence, but I shouldn't say eminence between some of us here on this side of the pond, that we add ursodeoxycholic acid if there is an immune-related cholangitis. It seems as if the patient do better with regard to the cholangitis. Again, there is no evidence, and in our European guidelines we have mentioned this, but that is something we are going to follow up, particularly for the biliary affection within the IgG4-related disease complex. Now, what is new on the block for the treatment in the future? Well, we mentioned the off-label medications, but there are clearly a whole array of drugs in clinical studies, some of them rather late, particularly phase 3 with the anti-19 antibodies, which are probably similar to the anti-CD20 antibodies, the best way to tackle from an immunological point of view this disease. So that is something we are looking very much forward, that those drugs which are then will be registered and approved for IgG4-related disease will become available for us and for our patients.
Yeah, that would be wonderful to see the therapeutic choices expand, especially for the treatment of patients with relapsing disease. Thank you for your comments. So thank you, Professor Löhr, for all your insights, and thank you to our audience for watching and listening.
Thank you.